Hi everyone, this is Mr. Neil Wrighter, also known as the Wax Whisperer. Thank you for tuning into my latest video. So I have a patient who had bilateral impactions in the left ear. So that was the first ear that we examined, and this is the ear that we're performing the procedure in first. The patient has impacted earwax. In the right ear, the patient has also got impacted earwax on the eardrum, but the view is obscured because the patient has also got a cotton wool tip lodged in his ear. They've been using Q-tips trying to get the earwax out, but conversely they only succeeded to impact it further in the ear. So I'm just using a Zollner suction probe to form microsuction. So this wax was literally cemented onto the eardrum. We just entered with the Zollner suction probe and gently removed that wax from the anterior recess. And the view, again, it's just amazing with the endoscope. You can see the entire eardrum and ear canal in one shot. So this is the patient's second right ear. I had to ask the patient several times whether they had been using cotton buds, because at first, although it was very apparent to me that they had because of the impaction, but at first they denied using cotton buds. And I wasn't sure. The reason why I kept wanting to ask was I didn't know whether this was cotton wool initially or whether it was dead skin or otomycosis, which is a fungal infection. And sometimes in the worst case scenarios, otomycosis, a fungal infection, can give the appearance of cotton wool fibres. So I started to use microsuction because, again, I wasn't sure, but it became very apparent very quickly that it is cotton wool. You're not going to suction cotton wool out the ear, or, well, it's going to be very difficult to use. So I'm just using some crocodile forceps. I'm just trying to get some purchase at the surface, trying to pinch into the cotton wool fibres, and we can then gently extract it laterally. And it was quite a big piece of cotton wool. I measured it at the end and it's just under 1.5 centimetres in length. So there is some residual earwax that has been impacted on the eardrum. So you can see the eardrum you can't see the normal landmark. So just using a fine end gauge to perform microsuction. And the patient did really manage to impact this on the eardrum, and I'm starting to peel this off the posterior segment of the eardrum. And then once I peel this all the way around, I then went into the anterior recess. So where we are now, we have a narrowing. You can probably see the ear canal narrows on the right hand side. You can see the ear canal goes inwards and then it goes back outwards. So we call that narrowing an isthmus. And when you've got a narrowing of the ear canal, it creates a recess anteriorly, so to the right-hand side. So it's like a hidden cave. And also inferiorly at the bottom, at the base, there's also a trench there. And quite often when patients and clients use cotton buds, they impact the wax so deep into the anterior recess, making it very difficult to remove because it can get lodged in the anterior recess, which it has in this case. I think now I'm going into the anterior recess, and you can see I'm just trying to manipulate this towards the left, trying to move it out of the anterior recess. But it is very difficult because the inner two parts of the ear canal, it's a very sensitive part. It's literally skin on bone, and if you make contact with the bony part of the ear canal, it can be very uncomfortable with the patient. And because the anterior canal wall, where the isthmus is, first it goes inwards and then it goes back out, there's a protrusion, so it's very difficult to, it can be very easy to make contact with that. You can see I'm slowly just dragging this forward, trying to roll it forwards, and it's out of the recess almost. And well, I would say now it is completely out of the recess. There's a little bit still attached to the eardrum there where I am at the moment, and I think I'm more or less loosened that. So I've just quickly gone back in with the full Zollner suction probe now that I've loosened it, because it does require a bit more suction power to extract. And you can see also there's quite a lot in the inferior recess as well. So that's the wax. That's the patient's tympanic membrane. There's a bit of residue. I did actually go back in, so if you continue watching, I just used a fine end gauge and I gently removed some of this debris and also that piece of less skin on the posterior canal wall. So you can see just the view we get with the endoscope. You can't replicate this view with any other visualization technique when performing clinical ear care. It's just a wide field of view, panoramic. It does take a bit of skill to learn the endoscopic technique, but once you've acquired that skill, the possibilities are limitless when performing clinical ear care. There's no part of the ear canal, I would say, that's inaccessible, whereas with some other techniques, other visualization techniques, there's some parts of the ear canal and eardrum that you just simply wouldn't be able to visualize. For example, the anterior recess. And not in the same way, because with clinical ear care, it's sometimes really important to be able to see the whole ear canal, because it helps you manipulate the plug of wax in one view. So I just measured that ball of cotton wool, so it's 145 millimeters. Sorry, 14.5 millimeters.